Thank you, Robin. It's my pleasure to speak to everybody today. So I'll be covering, one of the more common complications of multiple system atrophy, and that's what we call dysfunction of the autonomic nervous system. And so when we use the word autonomic, we just mean that it's an automatic function of the body. So some of the more common autonomic problems in MSA involve blood pressure and urination and digestion. And so we'll just kind of cover that and hopefully have plenty of time for your questions. So before getting into what can go wrong with these automatic functions in MSA, it's helpful to understand just what should be normal when things working correctly. So when we stand up, especially after lunch, like maybe right now, you can have up to 1 liter of blood. That a lot of the blood is sort of pools in your stomach area, and we call the splanchnic circulation. And then when we stand up, all that blood gets shifted down into the legs. And there are neurological mechanisms that prevent us from fainting normally, or prevent the blood pressure from dropping abnormally. And this is, a very complicated neurological slide, but basically what happens is there are reflexes in our brains, and they sense changes in blood pressure. And a lot of these sensors, they're really pressure sensors in the blood vessels in the neck and in the heart. And these pressure sensors will detect changes in the stretch of the blood vessels. And then they'll send signals to the brain stem and into the brain that will then send other signals down back to the blood vessels into the heart to keep the blood pressure and the heart rate pretty regular. So when we stand, if that blood pressure drops, we get a sense that the stretch in the blood vessels goes down, and so the signal goes down to the peripheral blood vessels in our legs and tells them to squeeze down, to constrict. The heart rate should go up, and the blood pressure should go up. Also, when, say, if we lay flat, our blood pressure is going to go up because your blood pressure is going to be higher when you're laying flat. Those same stretch receptors sense that and send the signal to dilate the blood vessels and to lower the heart rate. So this is a really intricate, evolutionary mechanism that keeps our blood pressures pretty regular, because we change position a lot. We walk on our 2 feet and then we lay down, and pressure is changing. But what happens in MSA is, because there's breakdown of these neurons in the brain, that the signals can't really get back to the brain, and they can't get back down to the blood vessels. So this process breaks down. And so the complication of this is very common in MSA. Probably 75% of patients at least have this condition that we call orthostatic hypotension. And this is just the medical term that means that your blood pressure drops more than it should when you're upright, and it doesn't come back up like it should. And so, when we check blood pressure, you have the top number and the bottom number. The top number is, we call the systolic pressure. That number is more important to us, like as neurologists, because it's more related to blood flow to the brain and sort of the symptoms you feel. And if that top number drops too much, you can faint. So if that top number is dropping more than 20 points after standing for several minutes, then that's not normal. It's okay for your pressure to drop right away, right when you stand up, like after lunch, you've been sitting, but within 10 seconds, that reflex that I showed you should kick in, and then your blood vessels in your legs squeeze down, and your blood pressure should come back to normal. But in MSA, and just like in Parkinson's disease, these other disorders where the nerves break down, the blood pressure can drop, but it doesn't come back up. And so that's what we call orthostatic hypotension, or OH. And there are a lot of causes of OH. It's not always due to MSA or brain disorders. The more common causes are just blood pressure medications that people are taking, being dehydrated, being anemic. As we get older, you get more blood pooling in your legs normally, because we get more varicose veins, and we lose muscle mass. Also, when you lose muscle mass, especially in your legs, your muscles have a lot of blood in them, so you can't pump the blood as easily when you stand. So losing muscle mass and losing weight as we age contributes to this. And another really important thing to emphasize is that if the blood pressure is dropping abnormally, it's not necessarily a problem. It's only a problem if we have symptoms. If we stand up and the blood pressure drops 20, 30 points, but there's no symptoms, we usually don't treat that. Symptoms, now a caveat is symptoms can be hard to recognize for whatever reason, and this is not really well understood, but there might be changes in the brain that in MSA and like in Parkinson's that don't allow us to sense or be aware that we have symptoms. So some people will just fall. And if you don't have symptoms, but there's frequent falls, that might be a reason to treat this. But if there's no falls and there's no symptoms, we usually don't treat orthostatic hypotension. So that's just important for everyone to know and for doctors to know. But if there are symptoms, what could those symptoms be? So typically, we all think of dizziness. That's a very common symptom. Lightheadedness. There's a lot of causes of dizziness. So it's always important to tease that out. I mean, is the dizziness much worse when you're standing and gets better or goes away when you sit down or lie down? That's a sign that you have orthostatic hypotension. Of course, people can faint, but actually that's less common. As people have this problem chronically, the brain actually probably regulates a bit and shunts more blood to the brain and keeps the brain, online, basically. Fainting means that there's a critical reduction in blood flow to the brain that will cause your brain to go offline and lose consciousness and get to the ground so you can sort of reboot, right? But with chronic orthostatic hypotension, the brain finds a way to get that blood flow, even though the blood pressure in the body is low. So actually fainting is not as common as people think. There's a lot of other less common symptoms that are less well-known symptoms. And these are things that everyone should be aware of. So even if you're not lightheaded, you could be maybe short of breath when you stand. You could have fatigue when you stand. You could be foggy or have cognitive slowing when you stand. There can even be chest pain with standing. And a really common symptom is what we call coat hanger headache, where you get cramping in your shoulders or your neck. And all of this is due to decreased blood flow to all these parts of your body. Decreased blood flow to the muscles in the neck, which causes cramping. So if there's any symptom that is much worse when people are standing, always want to check blood pressure. Always want to do a laying and standing blood pressure, and we can get into how to properly check blood pressure. And so when we measure blood pressure in, say, in an office, or if we can do it with continuous monitoring, like in the Autonomic lab, we can see something like this, where blood pressure is normal laying flat. Actually, it's usually high, but we'll talk about that as well. And then on standing, it drops pretty rapidly and to a pretty low number here. Someone would get lightheaded, they sit down, then it comes back up. And so it's a really simple thing to measure, and something doctors, we should all look at more. And honestly, a lot of us are lazy and don't always do this when patients are dizzy, but it's a very simple thing to measure, and a thing that we probably miss a lot of. So again, if you have orthostatic hypotension, it's not necessarily from a neurodegenerative disorder. If you have MSA, it likely is, but there might be some other non-neurological contributing factors that we should always go through. And the big one is typically medication. So any antihypertensive, any diuretic, basically anything that'll lower your blood pressure, obviously. Nitrates, so things given for chest pain, things like Viagra, these sorts of medications dilate blood vessels, so they're going to drop blood pressure quite a bit. Also, tricyclic antidepressants, nortriptyline, amitriptyline, these things can lower blood pressure. Trazodone is another big one. Trazodone for sleep can lower blood pressure. Anemia as well. So anemia, we always want to treat that. Making sure people are not dehydrated. And if there's any heart failure, or any other underlying cardiac cause that can contribute to it. So once that's all ruled out, then we have this term called neurogenic orthostatic hypotension. And that's what a lot of patients with MSA have. And this is due to just breakdown of the neurological structures that control that signal that I showed you. Breakdown of neurons in the brain, and sometimes breakdown of neurons in the peripheral nerves that go to the blood vessels. So the end result is that the blood vessels do not constrict because they don't, the nerves can't release this compound norepinephrine or noradrenaline. So when we stand up, there's a norepinephrine release, and that binds to the blood vessels and causes them to constrict. And this is not happening in patients with MSA. And again, orthostatic hypotension can be a very early feature of MSA. It can occur decades before, or maybe a decade before the other symptoms of MSA happen. So, it's what we call a prodromal feature, an early feature. So again, when to suspect orthostatic hypotension? Of course, if you have symptoms that are worse when you're standing, especially lightheadedness, but also if there's any unexplained falls or fainting episodes, and anybody on any medication that'll affect blood pressure. Basically, anyone with MSA, every time you see the doctor, they should be checking orthostatic measurements. We typically do first measurement laying flat, because you're going to see the highest blood pressure when you're laying flat. Usually you should wait 1 to 2 minutes after you're flat, check blood pressure, and then stand up. And if you're able to stand for 3 minutes, check it at 3 minutes. If you can't stand for 3 minutes, just go as long as you can. The reason we wait a couple minutes is because it's normal for that initial blood pressure drop, but it can come back up within a minute. You want to wait. If it's still low at 2 or 3 minutes, that's abnormal. If you have worsening symptoms, any of them on this list, just ask yourself, are they much worse when I'm standing? If so, do some orthostatic blood pressures. It's a very simple thing to do, with an arm, automated arm cuff at home. Wouldn't use the wrist cuff. They're not as accurate. So arm cuff, and just check blood pressures. You can give that information to your doctor. It's a very helpful data point to have. If you get an error reading on the blood pressure cuff, that probably means your blood pressure is too low to be detected, which means, it's another reason it should be treated. You can also get an error message if you have a tremor. So, maybe having a partner hold your arm, steady when you measure the blood pressure, if you're getting error messages. So just getting into, how do we treat this? Again, the first step is not to normalize the blood pressure, because no one with MSA is going to have a normal blood pressure. It's really to try improve symptoms, improve quality of life, reduce falls, make sure that you can be upright and be, moving around and not be limited by this. And so once it's diagnosed, you want to remove, medications that could contribute, treat anemia, all those things. And then before considering medications, it's non-medication-based treatment. And so what does that mean? Almost everybody with neurogenic orthostatic hypotension has supine hypertension. So blood pressure is very high when we're laying flat. And that's also a big problem over time, because blood pressures can be very high, like 100, 180, 200. And that's also due to breakdown of that reflex in the brain. The best way to treat that is to elevate the head of the bed by 30 to 45 degrees, which is not always comfortable. The best way to do this is with an electrical a mattress, an adjusting mattress, adjustable bed. You can use a wedge pillow, but that's pretty uncomfortable. So, a lot of patients will end up investing in a adjustable bed at some point, and that's the best thing to do. Compression garments, I don't usually recommend prescription grade garments, because they're very uncomfortable. They're hard to get on. They actually don't increase the blood pressure that much more than over the counter, just like athletic socks, like knee-high athletic socks. But if you really want to have a good compression garment, the best thing is an abdominal binder. So they're just these Velcro binders that people get for like low back issues, like $10 online. So you put that and keep that pretty tightly around your abdomen, and that'll kind of keep all that blood that usually sits in the belly from going down further into the legs. So abdominal binder is very helpful. It's very difficult for patients with MSA to drink this much water, especially with the urinary issues. But the goal is like around 2 liters of water, 64 ounces. Another tip, this is a very helpful practical tip, is that if there is a drop in blood pressure, if you consume as close to 500 mLs of water as you can, as quickly as you can, that's going to increase the blood pressure quite a bit, 30 plus points systolic. And so it's actually a reflex that happens in the stomach, and it has to be water. Electrolyte solutions won't do this. It's an osmotic reflex in the stomach. So drinking water quickly, especially if it's cold, will increase the blood pressure. And salt, the recommended amount of salt is usually 1 to 2 teaspoons. So what we tell patients is to get 2 teaspoons of table salt, put in a Ziploc baggie, just to give you an idea how much that is. And add that to your food, cook with that amount. As long as your blood pressure is not really high, meaning above 160 systolic when you're sitting consistently, then you can probably have as much salt as you want, generally, if you have OH. And then physical activity. Again, this is always the thing that we try and keep patients physically active, because as you start atrophying, the leg muscles especially, you're going to lose blood volume, and then your blood pressure is going to drop more when you stand. So we just want to do whatever we can to keep the lower body as conditioned as possible. And some helpful things here that you might be able to do more easily than others would be a recumbent bike or aquatic therapy. Exercising in water is very helpful, because the water also increases our blood pressure a little bit. And that's a good, if you have access to that. I know it's not the easiest to have access to, but so this is showing just what the blood pressure does with that water bolus. So if you drink one of these, Kirkland waters there, your blood pressure might go up 20, 30 points if you have orthostatic hypotension, and it's going to stay elevated for 30, 40 plus minutes. So, intermittent water bolusing, if you can do it, is a very effective way without a lot of side effects to increase blood pressure. This is just emphasizing that in MSA, there's a high blood pressure laying flat, and that blood pressure might actually go up when we sleep. So it's good to check some blood pressures like before bed. And if they're consistently high, sometimes we'll give short-acting blood pressure medicines at bedtime to lower the blood pressure, to keep it from going too high while you sleep. Of course, if you have to get up at night, like use the bathroom, you want to be even more careful, just sit on the side of the bed for a little bit before you stand up. But blood pressure is typically high, overnight, and that's something to be aware of. And so this is, the picture on the left is from a paper in JAMA in like 1940 something. This is how we used to elevate the head of the bed. And the old school would be to you put like telephone books, I think, under the head of the bed to get the whole bed up. Of course, if there's a bed partner, that's not the most popular thing. And now, of course, we have everybody has these now, right? The adjustable mattresses, and also helpful for sleep apnea. But this is probably the way to go if you can, to get an adjustable bed. And this is just showing that when patients with MSA exercise, their blood pressure drops. So when we exercise, if you don't have orthostatic hypotension, blood pressure increases. But if you have this breakdown of this neurological reflex, the blood pressure actually decreases. So you have to be real careful. I've heard too many stories of patients fainting on treadmills, and no treadmills, and just be very careful with upright exercise if you have orthostatic hypotension. So that's why the stationary recumbent bike is very good. Rowing machine or aquatic therapy. And this is just emphasizing that if you are in sort of waist high or chest high water, the blood pressure goes up by about 5 points. If you're in neck high water, which you probably wouldn't be, it's going to go up 15 points. But it doesn't drop, right, as much as if you were working out in a gym. So aquatic therapy is very good. Of course, if you feel like you could faint or pass out, best thing to do is get to the ground if possible. But if you can't and you're able to, tense your muscles, especially your leg muscles, that can help. And this is just showing how the blood pressure increases with each of these maneuvers. And this is actually what they would teach pilots to do when they were, before G suits, when blood pressure would drop, at high altitude, to prevent pilots from fainting. They would teach them to clench their buttocks and clench their legs, because that pumps the blood up to the brain. And so again, we really want to avoid the vicious cycle. If there's falls, physical inactivity, deconditioning, that's going to worsen orthostatic hypotension. So we really want to break that as early as possible by, number one, diagnosing the problem and then treating it with these non-medication treatments first. And then if we are going to use medications, this is a busy slide, but these are the ones that you'll typically see or hear about. And the most common one that started is Midodrine. It is effective. It's fairly cheap. So we'll usually use this first. And the way that Midodrine works is it binds to the receptors on those blood vessels in your legs and causes them to squeeze down. The other medication that's very similar is called Droxidopa or Northera. Droxidopa is generic now, so it's still kind of expensive, which is the problem. But it's probably a little bit better than Midodrine because it's a pure drug. It's converted to the chemical that is deficient that we should have released, but is not released in MSA, norepinephrine. And then that binds to that same blood vessel and causes constriction. So Midodrine and Droxidopa are constrictors. And then you'll also see a lot of fludrocortisone here, which increases salt absorption in the kidneys. It's a volume expander. You got to be a little careful with fludrocortisone because it's a very long-acting drug. So it's going to increase blood pressure all the time. So if you have a lot of high blood pressure when you're laying flat, it's not great. But of course, if blood pressure is dropping, not controlled with Midodrine or Droxidopa, fludrocortisone is used. We really prioritize preventing the drops, and we'll kind of deal with the high numbers as long as we can improve quality of life and prevent falls. But just be aware fludrocortisone is real long acting, so it's going to increase that blood pressure at night as well. And then finally, sometimes we'll use something called pyridostigmine or mestinon, and this probably just increases this neurotransmitter upstream, which downstream leads to the release of the norepinephrine and the constriction. It's just not as strong of a drug as these other ones, so it's usually sort of added on into the mix of these other three. A couple words on Midodrine. It's pretty short acting, so it's going to last 2 to 3 hours. So it's usually 2 or 3 times a day. We see this all the time. When these drugs are prescribed, they're written as like, take twice a day, take 3 times a day. So patients will take them morning, afternoon, they'll take them right before bed. And you don't want to take any of these medications right before bed because, number one, you're less active, you're just going to sleep. You want to be taking these when you're trying to be more upright and moving. And number two, they're increasing your blood pressure, and your blood pressure is going to be high when you're laying down anyway. So you don't want to just take something that's raises your blood pressure and then go to sleep. So you don't want to take any of these medications up to 3 hours before bedtime. So a good regimen is usually morning, like lunchtime, and then late afternoon. Droxidopa, it's the same. The good news, it's easy to remember this. It's really the same half-life as Midodrine. So you take it 3 times a day, like morning, lunch, late afternoon. And then fludrocortisone is just once a day. It's just 1 tab in the morning because it's super long acting, just once in the morning. Pyridostigmine, that's 2 or 3 times a day as well. Won't get into all the minutia here of the dosing. But yeah, those are the 4 drugs. Many of you probably have heard of these drugs. I usually would start Midodrine first. Droxidopa, if mitotin is not effective, then consider fludrocortisone, and then consider pyridostigmine, sort of fourth line. That's kind of how I typically think of these. And then again, this is just emphasizing the high blood pressure, really common when patients are flat. So just be aware of that. And if you're seeing really high numbers, elevate head of the bed, and then sometimes adding in a short-acting blood pressure medication just at bedtime to bring it down. Okay, so moving on, blood pressure is a big problem in MSA. The other big problem is urological issues, so issues with the bladder. And this can be one of the more debilitating symptoms in MSA and also one of the earliest manifestations of MSA. And I'm not a urologist, even though this does sort of cross over into what we do as neurologists in managing patients. We advise all of our patients to see a urologist and follow closely with them, because they're really the experts in these manifestations. But very common symptoms are bladder symptoms and then difficulty voiding. So overactive bladder symptoms would be symptoms of urinary urgency. You're having to go immediately, having to urinate frequently, urinate a lot at night. And by the way, if you have to urinate a lot at night, you always want to think about sleep apnea, very common and very treatable. So if you urinate a lot at night, think about if you snore, you should have a sleep study to look for sleep apnea. And then of course, incontinence as it gets more severe. And then there's symptoms where there's difficulty with the urination itself. So poor stream, poor flow, incomplete bladder emptying, or having to go, multiple times. And so, if you have any of these symptoms, you should see a urologist. They'll probably do a post-void residual ultrasound. And there's also testing called urodynamic testing, which may give a little bit more information. And, in research, using this post-void residual, we're actually doing this more with autonomic testing now in patients where we're suspecting MSA, because there's a lot of data that shows that if someone has a post-void residual less than 100, and they also have something like orthostatic hypotension, that's a red flag for MSA. And we should think about MSA versus say something like Parkinson's disease in those early patients. And then erectile dysfunction, one of the most common symptoms in men, occurs very early, very, very common. So again, all these treatments really should be kind of reviewed with a urologist. There's just some basic lifestyle changes like fluid management. Of course, I'm telling you that you should take drinking 2 liters of water. So it's difficult, but you want to avoid some of these irritants that can kind of worsen the urinary symptoms like caffeine, alcohol, spicy foods, and processed sugars. There's physical therapy if there's pelvic floor dysfunction, which can contribute. Constipation can contribute as well. And there's timing the urination. There's also several medications that are very effective. These newer medications, these beta agonists called Myrbetriq. In the past, there were medications like oxybutynin, ditropan that would have a lot of anticholinergic side effects. But now this newer class of medications don't have those. So there are medications that can help quite a bit with the bladder symptoms. And sometimes there's nerve stimulators as well, or even Botox that can help. So I just have a couple more slides and then we can get into questions. So just as a lot of our MSA patients follow with urologists, a lot of our patients also see our gastroenterologists because GI symptoms are very, very common as well. There's a, I think, fascinating developing field called neurogastroenterology, or disorders of the gut-brain axis. And I think we're realizing that a lot of neurological diseases affect the nerves of the gut as well. So it can cause slowing or it can cause rapid emptying. And if there is, say, slowing in the upper GI tract, like in the stomach, we call that gastroparesis. So you can get full easily, bloated, or nauseated with meals. And if it's slowed in the lower GI tract, you can get constipation, difficulty, going to the bathroom, defecating. And there's also a lot of pelvic floor dysfunction, and that can also sort of overlap with some of the urinary symptoms. And there's physical therapy that can be done for this. So GI doctors are the ones that kind of really specialize in kind of diagnosing some of this, and then maybe getting you to a pelvic floor physical therapist if that's the problem. And then kind of finally, another maybe less talked about autonomic problem in MSA is difficulty sweating. And we actually have this test that we can do in our autonomic lab where it's kind of like a sauna, and nobody wants to do this test, but it can give some interesting results. So we could have this powder that changes color when people sweat, and we put them in this sort of sauna-like room. And in MSA, you can see that, and this is a patient that had this test multiple times over several years, and it shows the progression of the sweat loss. And the sweat loss is due to breakdown of certain neurons in the brain that control the sweating. But after several years, as the disease progresses, you can have a near total loss of sweating in the body. And so this can cause overheating, heat stroke-like symptoms. If you're getting nauseated in the heat, this is just, something to be aware of. And there's not a medication that can really make you sweat, but it's good to be aware of it, and you can use cooling devices to cool the body down if that happens. 2 more slides. I don't think this maybe won't play the video. Yes, well, because I'm also a sleep doctor, I have to mention this disorder, REM sleep behavior disorder, what almost 100% of patients with MSA have. So if you're acting out your dreams or doing anything, violent or yelling, this is a common manifestation. And so patients actually act out the dream that they're having. And it can get quite violent. People have jumped out of bed and injured themselves. So if this is happening, you should have a sleep study to confirm it, but also taking some melatonin at bedtime is pretty effective at reducing the intensity of these episodes. And then finally, the other thing that we see in sleep, well, not commonly, but can happen in MSA, is stridor. Pause this. So stridor is difficulty in the vocal cords relaxing, and when people breathe out, it causes this very harsh sound, and it's a very dramatic sound. If you hear it, it's good to see an ENT doctor to see if the vocal cords are moving normally while you're awake, because this can be life-threatening, in some cases lead to aspiration. So it's something that if you're having this, it should be diagnosed, and also things like a CPAP or a BiPAP can reduce it and prolong life patients that have this disorder. So, okay, I'm at 30 seconds. So I just want to thank everybody, thank all the patients, and thank you for participating in research that we're doing, like with Dr. Robinson's lab, to try and understand this disease and lead to better treatments. I also want to give a shout out to Mission MSA, who has one of their focuses in this year has been to establish centers of excellence for MSA. So we just received, a small grant to start to develop a clinic of sorts, and eventually expand that into something more structured and to better treat patients. And so thank you, and open it up for questions.
Thank you very much, Dr. Miglis. This is a good transition because you mentioned the Mission MSA Centers of Excellence. Do all of the Centers of Excellence have an autonomic specialist like yourself?
Yes.
And do you recommend that every patient or family dealing with MSA see an autonomic specialist?
If you can, I mean, there's very few of us in the country. You don't need to. I mean, I think movement disorder doctors are familiar with the kind of main focus of that, kind of the main autonomic problems in our equipped to treat this as well. So it's not necessary, but yeah, it's certainly helpful if you can.
Okay. Somebody said orthostatic hypotension is very common in MSA, as you said, but is postprandial hypotension common as well? And can you, I don't know if you described what that was, but if you could describe what that is.
Yeah, so postprandial hypotension is blood pressure dropping abnormally after you eat. It's not as common as the orthostatic hypotension, but it can be a big problem. People can faint as well. So we usually treat that with medication. Midodrine is a good one to take about 30 minutes before eating. Caffeine will also help because caffeine is a vasoconstrictor. So having some coffee or caffeinated beverage, shortly after eating can also help for that. Yeah.
Okay, I've been pushing electrolyte drinks on my husband. Am I just giving him a placebo?
No, probably not. I mean, it depends on what is in the electrolytes. I mean, sodium is the most important in there. So, if you just consume salt and water, that's really the best. Electrolytes are more palatable, of course, because salt's like, no one wants to eat a lot of salt or take salt tablets. It's also nauseating. So a lot of these electrolyte solutions have sugar in them, which is okay, but that probably, if you're watching the sugar, you just got to pay attention to the contents. I mean, really, it's about the sodium. However you can get that in, that's the important thing.
And back to your baggie example, that was salt in 2 teaspoons or 2 tablespoons of salt?
2 teaspoons.
2 teaspoons of salt in a baggie and water in there?
No.
No, okay.
Yeah.
So that's your daily allotment. Or
yeah, I mean, if you can
that.
drink salt water,
Go for it.
some of our other patients that are younger that don't have MSA, that autonomic issues, they can do that, but that's not easy with MSA.
Okay. I've heard of people drinking pickle juice and Gatorade, of course, those kind of drinks too.
Another just easy way to get the salt is broth. Broths have a lot of salt in them, depending, you can make your own soup. You can have that salty, ramen broth and that sort of thing. There's a lot of salt in
potato chips.
Yeah.
Okay. Did you say that all MSA patients have REM sleep problems?
Almost all. Yeah, almost 100% do at some point in the disease. Yeah.
Are there any visual changes associated with orthostatic hypotension?
Yep, for sure. So anything from blurry vision to double vision to complete loss of vision, either a blackout, a whiteout, a grayout. So yeah, if the vision blacks out when you stand, it's due to decreased blood flow to the retina and the eye, or the brain itself, so that can happen. Yeah.
Okay, somebody says that they keep being told by their neurologist that they just have POTS. What might they be able to say to encourage the neurologist to consider MSA?
Sure. So this is a common issue, and I don't think a lot of doctors understand the difference between this thing called POTS and orthostatic hypotension, or OH. So POTS means that the blood pressure doesn't drop. The blood pressure stays normal, but the heart rate goes up, usually more than 30 beats on standing. That's not super common in MSA. If it is, it could be an early manifestation of OH. POTS is something we see more in younger women, say after viral infections, like with COVID and long COVID. It's not really common in MSA. So I would say just tell your doctor to just be absolutely sure that the blood pressure is not dropping and it's being measured correctly, laying flat, and then after at least 3 minutes of standing. Yeah.
Oh, somebody says, what about dizziness or lightheadedness in MSA that is not positionally driven? What could they do?
Yeah, like I said, dizziness is really common, just, as a neurological problem, and dizziness is common in, quote, healthy people. And, what we think of as neurologists for non-positional dizziness would be some inner ear problem, probably number 1, or migraine, number 2, or medications. But some vestibular sort of vertigo inner ear problem, that would be where I would, look for that.
Okay, you mentioned medications. Did you mention that levodopa, carbidopa can drop blood pressure? I didn't
I
know if you-
didn't, but
okay.
that's a good point. I mean, not as many, I guess, MSA patients take that, but a good amount do.
Mhm.
But yes, levodopa does drop blood pressure. So if you're taking that and you're being prescribed a medication like midodrine, we'll usually, dose them at the same time to kind of help prevent that drop. Yeah.
Okay, somebody asked about low vitamin B12. Is that related to orthostatic hypotension or anything you know about?
It shouldn't. No, it doesn't cause OH, but I mean, it causes a lot of other neurological things. So I usually say if it's less than 400 to take at least an oral B12 supplement. Anemia does. And anemia, not directly because of the anemia, but anemia actually increases something called nitric oxide, which is a blood vessel dilator. So, you always want to treat anemia if you can.
Okay, somebody, you mentioned in your talk that there were 4 medications for orthostatic hypotension. Somebody says they've tried 3 of them. I don't know which of the 4th they haven't tried, and they're still experiencing a 40 mm drop in blood pressure. What might you suggest?
So there's a couple other ones that I didn't put on here that are sort of like the Hail Marys when that's not working. But low risk one would be atomoxetine or Strattera. There's actually a clinical trial right now. It's enrolling MSA patients with a sort of analog of that drug called ampreloxetine. But atomoxetine increases norepinephrine. Again, it's a lower dose than you take for like ADHD. It's typically used for ADHD. So, if you want the dose, it's 18 milligrams. It's a low dose, pretty low risk. And then the other one is desmopressin, which has a higher risk of low sodium, which can be life-threatening, but at low dose, it's, if sodium is monitored, it's safe. So desmopressin at night is something that we also think about.
Okay. Are there any long-term effects in using clonazepam for a REM sleep behavior disorder?
Sure. Yeah. So good questions. There
got
are, but I'd say if you've already tried melatonin and you've gone up, I usually go up to like 12 milligrams, and you're still having violent dream-related episodes, you want to prevent injury. So clonazepam, I would like that dose to be not much higher than 0.5 milligrams, at the most 1 milligram. But yes, it can cause cognitive impairment and it can affect your balance. But if you need to take it, then it's okay, right?
Okay, last question. Do certain foods cause more severe drops in blood pressure, dairy, high fat?
Yeah, and I mean, I should have covered all this. These are good questions. So carbs, so simple carbohydrates are the biggest problem. Pastas, breads, there's simple white, flour foods because those cause a lot of blood flow to the stomach. So carbs, yeah.
Thank you very much, Dr. Miglis. Appreciate it.
Thank you.